I'm going to discuss the epidemiology, presentation, complications, therapy, and outcomes of patients with PBC and PSC. I'm going to be including some latest updates over the last 3 years on each subject. So PBC and PSC always get lumped together, but today hopefully I will show you that these are two completely different diseases with different complications, management strategies, and outcomes. That being said, the reason they do get lumped together is because they both present with a predominantly cholestatic liver injury pattern. So what is cholestasis? It's Greek in origin. It means bile stoppage. In its most overt form, it presents as jaundice. In early stages, cholestatic diseases leads to a preferential increase in the cholestatic enzymes, your alk phos and your GGTP, as opposed to the hepatocellular enzymes, AST and ALT. If that's too confusing, here's a cartoon illustrating cholestasis.
Dr. Malik, I'm sorry, I don't mean to stop you. You are not screen sharing right now. Would you mind retrying to screen share?
Sorry about that. How about now?
Yes, there we go. Thank you.
Okay, sorry, you missed my funny slides. Anyways, I'm gonna just move on to here. So as you all know, the liver is the largest internal organ. It sits in the right upper quadrant. On the underside of the liver is the gallbladder, and the gallbladder is connected throughout the entire liver in an intricate duct-like system. These ducts are intertwined amongst the millions of liver cells or hepatocytes. And one of the functions of the hepatocytes is they make a thin green liquid called bile. This bile is then stored in the gallbladder. And when food passes into the intestine, the gallbladder contracts and that bile spills out into the duodenum and helps break down food. If for whatever reason this bile doesn't get out, for example, if it's blocked or inflamed, it ends up in essence being toxic to the liver, causing inflammation and ultimately scarring and fibrosis. There are a lot of diseases that lead to cholestasis. Today we're going to be focusing on the two most common in the United States, which are PBC and PSC. So just how rare are PBC and PSC? Relatively speaking, they are rare, but we see these diseases quite frequently in our clinics. Estimates in the United States, PBC about 100,000 folks and PSC about 50,000. So I'm going to start off with the clinical case. Here's a story of a 49-year-old female who's referred to your clinic for abnormal liver function test. She's had mild elevation in her alk phos for 18 months, but it has been steadily rising. She complains of itching and fatigue, and on review of systems, she does complain of dry eye. Socially, she has no habits. She doesn't smoke or drink. She's married. She has 3 daughters. Her family history, her grandmother died of an autoimmune liver disease. On exam, she has some yellow deposits around her eyes. Her BMI is 28. So her lab tests show a predominantly cholestatic injury with an alk phos about 3 times upper limits of normal. Her total cholesterol is elevated at 278. And her chronic workup reveals a positive anti-mitochondrial antibody. So you confirm the diagnosis of primary biliary cholangitis. You obtain an ultrasound, which shows relatively minimal fibrosis, and you initiate her on weight-based ursodeoxycholic acid. A follow-up in 6 months reveals that her liver enzymes are now normal. So PBC, the name was officially changed in 2015 from primary biliary cirrhosis to primary biliary cholangitis, and for good reason. We'll discuss why that is in a bit. It's a chronic liver disease resulting from progressive immunologic destruction of the small intralobular bile ducts, or microscopic. And that's an important point when we differentiate between its sister disease, PSC, which typically affects the large or gross ducts. PBC may ultimately result in cirrhosis and liver failure. It's immune mediated. There probably is a genetic component, as familial clustering shows a prevalence of 100 times higher in first-degree relatives when compared to the general population. 90% of patients are female. It typically presents in the 4th and 5th decades of life. Fatigue and pruritus or itching are the most common presenting symptoms. Abdominal discomfort, less so. 50% of patients are asymptomatic, and the referral is made on routine surveillance blood work in those patients. The prevalence is anywhere from 19 to 400 cases per million, but there is evidence that the disease burden may be increasing. The etiology remains unknown, but again, is probably a combination of autoimmune and genetics. So how do you make a diagnosis of PBC? You need two of the three following. You need a predominantly cholestatic pattern in your enzymes, a positive AMA, which is positive in about 95% of cases. It's traditionally regarded as one of the most sensitive and specific markers in all of medicine, plus or minus histological evidence of PBC. So this is the pathognomonic histological lesion in PBC, an intense inflammatory infiltrate of lymphocytes and plasma cells centered around a bile duct. So in the middle here, you can see a bile duct, and all of these blue cells are inflammatory cells destroying this bile duct, at least on a microscopic level. Another classic finding in PBC is shown here, a non-caseating granuloma. In the United States, if you see a granuloma on liver biopsy, PBC should be somewhere on your differential. Additional lab findings are not uncommonly found during a workup for PBC. ANA can be seen in up to 70% of patients. And you should always be aware of PBC autoimmune overlap, especially when patients have transaminases that are in the 200 to 300 range, or if patients don't adequately respond to URSO. IgM will be elevated in a vast majority of patients, and then serum lipids can be elevated in greater than 50% of patients, although interestingly, data suggests that it does not seem to lead to an increased risk of cardiovascular events. So there's a lot of physical exam findings. Xanthosma are one to be aware of, which are seen in about 10% of patients, these little yellow deposits, which are actually cholesterol deposits centered around the eyes. Autoimmune diseases have a tendency of running in bunches, so it's not surprising to know that patients with PBC frequently are diagnosed with other autoimmune diseases, namely Sjogren's or dry eye, dry mouth in about half of patients, thyroid disease, scleroderma, arthropathy, and celiac disease in anywhere between 5 and 8% of patients with PBC. So the goal of therapy is to halt or potentially reverse the progression of disease, specifically fibrosis. So there's no cure for PBC like other autoimmune liver diseases. These are chronic conditions that are generally lifelong. They can be managed, but are unlikely to be cured. So when it comes to liver disease, the big concern is the development of scar tissue. We grade scarring in the liver out of 4 points. So a normal healthy liver has 0 scar tissue, and a patient with cirrhosis has complete scarring, or a 4 out of 4. Now, this particular time frame I'm showing here is with regards to fatty liver, where only about 5 to 8% of patients will progress to cirrhosis in a time span of 30 years. Translating this into PBC and PSC is a little bit more difficult, but at least when it comes to PBC, it never presents acutely. You don't wake up one day and are jaundiced or in liver failure. In general, it takes decades to develop advanced disease. That being said, there are a handful of patients that progress more rapidly, and we'll discuss those in a bit. So what exactly is fibrosis of the liver? Well, it's very similar to any injury you sustain. So if you cut your hand, initially the cut is red and inflamed, but over time, as it heals, it forms scar tissue. The problem is scar tissue is dead tissue. It has no life. Now imagine completely scarring an entire organ. It can potentially lead to serious problems. But these terms are critically important for patients to understand. Only a minority of patients with PBC will end up developing cirrhosis. And that was good that they ended up changing the name from primary biliary cirrhosis to cholangitis. But if you do progress to cirrhosis, you're then at risk of developing all of the complications we see from liver failure. And these are life-threatening complications that carry a very high risk of death. And whenever these occur in a liver patient, we can treat some of them medically, but ultimately the best treatment in these cases is to take out the old diseased liver and put in a new liver, or what we term liver transplant. So this was a gastro paper published in 2000 by the Mayo Group, following 46 patients with PBC from Olmsted County in Minnesota. 10% of patients went on to require liver transplant. A third of patients developed complications of end-stage liver disease, and 20% of patients ended up succumbing from their liver complications. So things were not great if you had PBC before therapeutic options. But fortunately, the outlook has changed dramatically over the last 25 years. The first-line therapy for primary biliary cholangitis is ursodeoxycholic acid, or Actigol. It's generally weight-based, 13 to 15 milligrams dosed BID. The response rates are about 70%. So generally what you do is you start a patient on weight-based therapy and then reassess their enzymes in 6 months to a year. Near normalization of the enzyme is the goal of treatment. Long-term cohort studies suggest that if you're able to normalize the enzymes, the outlook in those patients is very good. So PBC used to be one of the more common indications for liver transplant, but since the approval of ursodeoxycholic acid, the prognosis of patients with PBC, as mentioned previously, is quite good. Here's a picture of my daughter talking to Dr. Starzl about the good old days when many of his transplants were for PBC. So URSO was officially approved in 1997. You can see in 1989, about 20% of all adult liver transplants in the United States were for PBC. Currently, it accounts for less than 5%. This same holds true in Europe. This is a nice paper looking at a 30-year span of trends of PBC and liver transplant. So PBC as an indication for liver transplant has declined by 5-fold. So I mentioned the goal of treatment is to prevent fibrosis. So how can we assess this? We obviously can't constantly biopsy patients or routinely do elastography measurements. So we use blood tests as surrogates, and there is good data to suggest that in PBC, for example, as opposed to PSC, blood tests can be a reliable marker of disease progression. This is a study published in the Red Journal about 2.5 years ago, over 2,000 patients with PBC. So if you get a patient's bilirubin less than 1 after the initiation of treatment or normalize their alkaline phosphatase, it was associated with a greater than 90% 10-year transplant-free survival. So the outcome in responders who normalize their liver test is quite good. GGT is thought to be a more specific marker of cholestasis. This was a study looking at that same 2,000 cohort of patients. 91% were female. The mean diagnosis was 53 years of age. If your serum level of GGTP at 12 months after treatment was higher than 3-fold, that portended a worse diagnosis. So these are blood tests that we can routinely check on our patients and then reevaluate them 6 months to a year into treatment to help determine prognosis. So what about non-responders to URSO? Studies suggest, again, that about 70% of patients will end up responding. Who are the non-responders? In this large study from the PBC study group, it showed that younger patients in particular, specifically those under the age of 35, were the most difficult to treat with a hazard ratio of near 15. Fortunately, you won't see many of these patients. I probably only have 5 or less than that of PBC patients under the age of 35. What can we offer to non-responders? So there is a derivative, a quinodeoxycholic acid, typically used in conjunction with ursodeoxycholic acid, but there are some small studies looking at monotherapy. So obeticholic acid was approved largely based on this study published in Gastroenterology in 2015, and it was officially FDA approved in May of 2016. This is the most recent paper evaluating the real-world experience of obeticholic acid. There are now multiple papers documenting the real-world experience. In this study, nearly 200 non-responders to URSO were followed for 1 year. Obeticholic acid was added to their regimen, and 43% of patients were deemed responders. Response was seen less commonly in cirrhosis. There was a 15% discontinuation rate, mainly related to pruritus, which is a known side effect of the medication. Briefly, there is off-label use of fibrates. I'm just going to skip through this, but bezafibrate, for example, there was a study published in the New England Journal 3 years ago, a phase 3 study of 100 non-responders to URSO, and bezafibrate did seem to have a role. These drugs are more commonly used in Japan, but some of my colleagues are using them off-label in patients that do not respond to URSO. So again, therapy is most helpful when initiated early in the disease course, patients who have relatively minimal fibrosis. But what about those who have advanced fibrosis or cirrhosis? This is the largest study evaluating the role of URSO in PBC patients with cirrhosis. This was a VA study, so a majority of patients were male, but this can probably be extrapolated to our female population. 500 patients with compensated cirrhosis, so these were not patients that were in liver failure, they just had advanced scar tissue. URSO response was associated with a 60% reduction in liver-related death or transplantation. It did not, however, seem to reduce the risk of hepatocellular carcinoma. So speaking of hepatocellular carcinoma, this was a large study of 22,000 patients with PBC. The incidence of HCC was about 15 per 1,000 patient years, so roughly about 1% per year. Much less than it is in Hep C and Hep B, but higher, for example, than it is in autoimmune hepatitis. The two biggest risk factors for the development of hepatocellular carcinoma in patients with PBC is cirrhosis. So you only need to start surveying a patient when they have complete scar tissue, and male gender. Males on average had about a 5 times increased risk of developing liver cancer as opposed to their female counterparts. So are there ways we can predict the outcome in patients with PBC? There are several online scoring systems that I've listed here. I would encourage you to play with these a little bit. I'm not a big fan of the Mayo score, but some of the others I think do have some clinical utility where you can put in data points before and after the initiation of therapy, and they help predict outcomes. I think more and more liver stiffness will be our ruler to determine outcomes in patients with chronic liver disease. This was a study of over 500 consecutive patients with PBC from the Mayo. Half of them underwent transient elastography and half of them MRE, and about a third underwent concomitant liver biopsy, and the accuracy was quite good in predicting fibrosis. So for example, if you're doing MRE at your center, 4 is a good number to remember when it comes to an increased risk of decompensation in patients with PBC. So you're not going to successfully treat everyone. I would say in Pittsburgh, we end up transplanting still about 5 to 10 patients per year with PBC. Fortunately, their outcomes after transplant are quite good. This was a large study detailing the outcomes of 8,000 patients undergoing liver transplant for PBC over a 25-year time frame. The 5-year survival of those was 80%. So that may not sound great, but remember, we're only talking about transplant when we think a patient's 1-year survival is not good. In this particular cohort, the mean MELD score was 21. So a majority of these patients would have succumbed to their liver disease if not transplanted within 1 year. Like many of the autoimmune liver diseases, PBC does recur after transplant. In this particular study of nearly 800 patients, recurrence was seen in nearly 1 in 3 patients at 10-year follow-up. This was an excellent study that was just recently published a year ago in the Journal of Hepatology. evaluating the prophylactic role of URSO in patients transplanted with PBC. So again, recurrence of PBC after liver transplant is frequent. In this study, they studied the role of URSO as a prophylactic measure to prevent recurrence, and it was associated with reduced risk of recurrence with a hazard ratio of 0.41. It also reduced graft loss, liver-related death, and all-cause death. It also led to a survival benefit of 2 years. So based on this study and several subsequent studies published this year, URSO, in my opinion, should be standard of care in all patients transplanted for PBC in order to prevent disease recurrence and potentially improve survival. So my last slide on PBC, acute on chronic liver failure, has become a hot topic. This was somewhat of a surprising study, a retrospective cohort of 15,000 UNOS database patients listed for liver transplant with cirrhosis and acute on chronic liver failure. Between 2013 and 2019, there were about 400 patients with PBC. And interestingly, patients with PBC had the highest waitlist mortality of any group, 20%. So this purple top line is patients with PBC and acute on chronic liver failure. The yellow line is NASH patients. So again, they have the highest mortality. On the flip side, if patients with PBC and acute on chronic liver failure make it to transplant, their survival is excellent at 90% at 1 year follow-up. So my 10 take-home points regarding PBC. Number one, PBC is an autoimmune destruction of the microscopic bile ducts. It does not require a liver biopsy for diagnosis. 2, weight-based URSO is first-line treatment. 3, bilirubin, alkaline phosphatase, and GGTP can be used to determine treatment response after 1 year. 4, if your labs are not near normal, you should move to a second-line agent, namely obeticholic acid. 5, responders do well. URSO, even in cirrhotic patients, does seem to decrease the risk of progression. 6, younger patients and male patients seem to have more aggressive disease. I didn't mention this, number 7, but you should screen for thyroid and bone disease. You should aggressively treat pruritus because it does affect quality of life. 8, cirrhosis and male gender are the biggest risk factors for hepatocellular carcinoma. 9, the number of patients requiring liver transplant for PBC is declining, and the outcomes after liver transplant are good. And 10, disease recurrence is seen in about 25% of patients, and URSO should be standard of care to prevent recurrence. So I can take some questions there. If there's no questions, I'll move on to the second portion of my talk, which is sclerosing cholangitis.
Alex, I don't think we have any questions. I think we can move on.
Sure.
To PSC.
So I'm going to use itching as a transition because it does affect both patients with PBC and PSC. So this study suggested that itching is very common in patients with cholestatic liver disease and is probably undertreated. Less than 50% of patients receive medical therapy. Here's a step-by-step approach on how to treat pruritus. Generally, first-line agent is cholestyramine, but a lot of these other agents are very effective. But patients do need to be monitored, especially with rifampin because of risk of liver injury. This was a randomized study again, looking at fibrates in the treatment of cholestatic liver disease. This was published in Gastro a year ago. Again, bezafibrate in particular is not available in the US, but some folks do use fenofibrate off-label, and it does seem to be not only effective in reducing enzymes, but also in treating symptoms. And this study looked at both patients with PSC and PBC. So again, we should try to treat pruritus aggressively, although this guy doesn't seem to mind itching all that much. So moving on to PSC, here's a story of a man named Brady, 27-year-old male, referred to your clinic for abnormal liver test. He's had mild elevation in his test for 2 to 3 years. However, his alk phos has been steadily rising over the last 9 months. His viral serologies and ultrasound from a year ago are relatively normal. He has no other significant medical history. On review of systems, he says he has irritable bowel syndrome. He has loose bowel movements that he attributes to stress. He works as a social worker. He's single. He has no habits, doesn't drink. His father does have Crohn's disease. So on exam, he's thin, well-appearing gentleman. His CBC and BMP are normal, but his lab tests are elevated, very similar to our patient with PBC. So alk phos about 3.5 times upper limits of normal. His chronic liver workup is completely unrevealing. So you confirm your clinical suspicion for primary sclerosing cholangitis based on an MRCP. So I want you to focus in particular on this bile duct radical. You can see it has this classic, what we call beads on a string appearance. So areas where the bile duct is pinched off, but then areas where it's dilated as well. So a favorite internal medicine board question, what's the first test you should do when you confirm the diagnosis of PSC? And the answer, of course, is a colonoscopy. So you perform one in this patient and it reveals moderate colitis confined to the last 15 centimeters of his colon. The patient is placed on urso at a starting dose of 10 mg per kg in divided doses. He started on mesalamine suppositories. His bowel symptoms improved dramatically. However, his LFTs only show mild improvement and at 6 months are still elevated at 400. So PSC is a chronic progressive disorder of unknown etiology, thought perhaps to be immune mediated, that is characterized by inflammation, fibrosis, and stricturing of the medium-sized and large ducts, as opposed again to PBC, where the injury is on a microscopic level. The incidence for PSC is about 1 in 100,000 person years, about 40,000 cases in the United States. So you can see the demographic is very different than PBC. A majority of patients are male, and it typically affects younger males. 80% of patients have concomitant inflammatory bowel disease, more so ulcerative colitis than Crohn's. 50% of patients with PSC are asymptomatic at the time of diagnosis. Itching, again, is not uncommon. Signs and symptoms of cholangitis, meaning an infection in the biliary tree, usually related to a blockage, is a serious complication. Predominant cholestatic injury, the transaminases in patients with PSC is typically not very high, usually in the 100 range. Unlike PBC, there is no serologic gold standard for the diagnosis. It's not uncommon to have elevated immunoglobulins and p-ANCA seen in a fair number of patients, but there's no blood test where you can hang your hat on the diagnosis. The diagnosis of PSC is made on a cholangiogram. So a cholangiogram or X-ray of the bile duct shows the characteristic bile duct changes, multifocal strictures, and segmental dilations. Generally, we're using MRCP to make the diagnosis as opposed to the invasive test of ERCP, given the risks associated with that test. Biopsy is rarely diagnostic. A majority of patients, 87% of patients with PSC, will both have disease of the intrahepatic ducts, so the ducts within the liver, and the extrahepatic. So here's a nice cartoon depicting the stricturing seen in patients with PSC, and here's a cholangiogram on the bottom right. Here's an ERCP image. Again, you can see these areas where the bile duct is pinched off and then areas where it's dilated, again, giving that classic beads on a string appearance. Most patients with PSC will not end up getting a liver biopsy, as the diagnosis is made on cholangiogram in 90% of cases. Those that do get a biopsy, this is the classic finding, concentric fibrosis, many times referred to as onion skinning. It does sort of look like an onion. There are several variants of PSC that we should be aware of. IgG4, a small duct disease, which is made not, the diagnosis is made not based on cholangiogram, but on a biopsy. This is about maybe 5 to 8% of patients with PSC. They generally have a more benign course than large duct disease. And then there is a rare overlap of PSC and autoimmune hepatitis, although overlap is more commonly seen in PBC. So I want to spend 1 minute on IgG4. IgG4 related sclerosing cholangitis is a distinct type of cholangitis. It frequently is associated with autoimmune pancreatitis and is considered the biliary manifestation of IgG4 related disease. It can present just like PSC with obstruction and diffuse stricturing. However, this disease entity has exquisite response to steroids, and that's why the diagnosis is so important, although the diagnosis many times is challenging. There are 4 subtypes. Type 1 is the most common, where the stricturing is exclusive to the extrahepatic duct. Again, it's commonly seen in autoimmune pancreatitis. Histology many times will show an elevated IgG4, as will serology. So you should look for other organ involvement when you're trying to differentiate between PSC and IgG4 disease. Most experts do recommend checking an IgG4 in all patients with PSC to sort out the variant. Ultimately, in my experience, response to steroids is what helps clinch the diagnosis. Classically, PSC will not respond to steroids and actually can be harmful because it can induce bouts of cholangitis. There are many complications associated with PSC. I'm going to focus today just on a couple. We're going to talk about cholangiocarcinoma, dominant strictures, and a little bit about colorectal cancer. So cholangio is the most feared complication associated with PSC. Cholangiocarcinoma is now the leading cause of death in patients with PSC. There's a 400 times increase risk compared to the general population. It occurs in 6 to 20% of patients with PSC and accounts for nearly half of the deaths. 50% of the time, cancer is diagnosed in late stages, and when the diagnosis is made, the mortality, unfortunately, approaches 80%. Interestingly, it's detected in the first year in up to a third of cases. The big risk factor is a dominant stricture, which we'll talk about, but it has also been linked to smoking and alcohol. Cirrhosis, as opposed to hepatocellular carcinoma, so in primary liver cancer, meaning HCC, it is almost exclusively seen in the setting of advanced liver disease. That's not the case necessarily in PSC. You can develop cholangiocarcinoma very early in the onset of the disease. Cholangiocarcinoma should be suspected in patients with a sudden clinical or biochemical deterioration or with a new dominant stricture. So every dominant stricture should prompt an ERCP and sampling of the stricture. Surgery is the only potential curative treatment if diagnosed early. There is a little bit of controversy regarding screening. However, most experts recommend yearly imaging, especially again, within the first few years of the diagnosis. A lot of us do use CA19-9 and CEA, but they have low positive predictive value. Again, surgery is a prerequisite for the cure, but very few patients are candidates for resection because a lot of times this disease presents with advanced disease. Most patients will end up receiving concomitant adjuvant therapy, chemo, or radiation. Liver transplant can be considered in select patients with early stage cholangiocarcinoma in the setting of PSC, including early stage unresectable hilar tumors, after they've completed rigorous staging and neoadjuvant therapy. Some centers, including ours, are now doing intrahepatic cholangio under study protocol. There was a large study published earlier this year, a meta-analysis of 400 patients with cholangio. And in patients who had received neoadjuvant therapy prior to transplant, the 5-year survival was 65%, which is far superior to surgery, at least in select patients. So when cholangio does occur, it typically occurs in the extrahepatic duct. Again, if it occurs in the extrahepatic duct, the patient is generally sent for surgery and resection and bile duct reconstruction. If it occurs in the hilum, classically known as a Klatskin's tumor, or intrahepatic, in the right set of patients, there may be a role for liver transplant. The incidence of cholangiocarcinoma in PSC patients is highest in the US. I suspect this may be a detection bias, but there's no doubt it's one of those diseases. If you look for it, meaning cholangio, in patients with PSC, you're going to end up finding it. Like PBC, there are prognostic scoring systems in patients with PSC. The Mayo Group, of course, has a score for everything. There's another UK PSC score. I kind of like this one, which is the Amsterdam-Oxford model for PSC based on this large study. Basically, you input 7 different parameters into this online calculator, including whether it's large duct disease, small duct disease, age, and then a bunch of blood tests, and it will compute a nice survival curve over the next 15 years, giving you patients transplant-free survival. Again, more and more of us are utilizing stiffness to help predict prognosis. This study from Gastro over 7 years ago showed that stiffness in patients with PSC does correlate well with stage of fibrosis. But of course, as opposed to PSC, fibrosis is only one factor when it comes to predicting outcomes in patients with PSC. Ultimately, liver transplant is the only treatment for end-stage PSC or patients with recurrent cholangitis. While the top indications for liver transplant, namely NASH and alcohol, have been going back and forth over the last few years, liver transplant for PSC and really all of the autoimmune diseases has remained relatively constant. PSC in particular, about 5 to 10% of transplants in the United States. So therapy for PSC, this part is quick. There are none. So a bunch of medications have been looked at for the treatment of PSC, and unfortunately, none have panned out. The story of URSO in PSC deserves special mention. So this was a famous paper published by Keith Lindor and colleagues over 10 years ago in Hepatology. 150 patients were randomized to receive high-dose URSO, meaning 25 to 30 mg per kg. So again, remember in PBC, we use half that dose. And surprisingly, patients on URSO did far worse in terms of complications related to portal hypertension and the need for liver transplant. This study led to every major guideline recommending against the use of high-dose URSO. However, that same group then came out a couple of years ago and suggested that there may be a role for a more moderate dose, again, kind of the PBC dose, 13 to 15 mg per kg. So for example, the European guidelines give an option for a 6-month trial to try to tease out the PSC patient who will be a responder to, low or moderate dose URSO. The bottom line is nobody knows, and frankly, the literature is kind of a mess when it comes to the role for URSO and is really unhelpful in trying to sort out this issue. I do want to mention one quick word. We know that patients with PSC and IBD are at an increased risk of colorectal cancer. To date, the data regarding chemoprevention, in other words, medication to decrease the risk of colorectal cancer in patients with PSC, is weak, and so no strong recommendation can be made. There's not a ton of studies looking at new medications for PBC. This one was published about 2 years ago, an FSR agonist, perhaps showing some promise, at least when it comes to improvement in enzymes. The frustrating thing is if you look carefully at the hepatology paper from 2009, patients on high-dose URSO actually had better enzymes than their counterparts, but worse clinical outcomes. So who knows if numbers are really that important when it comes to PSC as opposed to, for example, PBC. So I wanted to end on discussing ERC for dominant strictures in patients with PSC. A dominant stricture seen on imaging, as I had mentioned previously, should prompt an ERCP in brushings. This study published out of Gut suggested that if you discover a dominant structure, even if a patient is asymptomatic, you should dilate that stricture and continue to dilate it until resolution. And that does seem to lead to a significant improvement in transplant-free survival. So you can see patients that underwent a protocol of serial dilation as opposed to symptomatic dilation did far better. That being said, you have to be cautious about doing ERCP in patients with PSC, especially those with advanced disease. This study published out of India suggested a really unacceptable mortality rate related to ERCP when the MELD score is greater than 18 with a 1-month mortality of 8.5%. So ERCP in patients with PSC should really be done at specialized centers and using a multidisciplinary model of hepatologists and therapeutic endoscopists. So my top 10 take-home points for PSC. PSC is a diagnosis made on cholangiogram. We use MRCP as opposed to ERCP. Be aware of variants, namely IgG4 and small duct disease. 3, cholangiocarcinoma is now the #1 cause of mortality in patients with PSC. Surveillance should be undertaken, especially within the first few years of diagnosis for cholangiocarcinoma. 5, all patients with PSC require colonoscopy to evaluate for IBD. 6, a change in clinical status should prompt evaluation for a dominant stricture. 7, evidence does suggest that scheduled ERCP with dilation may have transplant-free survival benefit. 8, frustratingly, there is no FDA-approved therapy for PSC. High-dose URSO must be avoided. Could there be a role for lower doses? I think the jury's still out. 9, ultimately, liver transplant will be required in 50% of patients. And 10, just like PBC, recurrent disease is not uncommon post-liver transplant. So thank you. My email address is there on the bottom. If patients have questions or viewers have questions, they can feel free to email me.